to AETCM EM Rapid 2022, and this particular video we will be discussing about bronchiolitis, croup, and pediatric asthma. So let's begin. Our first topic would be bronchiolitis. Now, bronchiolitis is the most common lower respiratory tract infection in infants and children less than 2 years, but it generally is seen in infants. And it's the leading cause for hospitalization in that age group, that is less than 1 year of age. And the most common cause of bronchiolitis is respiratory syncytial virus, that is your RSV, and it will be caused by many other viruses, including the adenovirus, the influenza virus, the metapneumoviruses, rhinoviruses, and parainfluenza viruses also. But it's predominantly by the, or rather most commonly by the RSV virus. Now, what happens is in the lower respiratory tract, inflammation begins, which is caused by these viruses and will result in edema, epithelial cell necrosis, bronchospasm, and increased mucus production. That is within the bronchioles. So you have the bronchioles. Because of the virus invasion, there will it'll set off the whole inflammatory process, and because of this, there will be edema, there will be increased mucus production, bronchospasm, and epithelial cells will necrose. So this would be the pathophysiology of bronchiolitis. Then it causes other issues also, like various degrees of air trapping because of bronchospasm, and also because of the resultant edema and increased mucus production. There can be atelectasis, that is nothing but the collapse of the alveoli, and hyperinflation of the lower airways, again secondary to your bronchospasm, just like how we see it in asthma also. So because of this bronchospasm and hyperinflation and air trapping, there will be increase in the airway resistance, and this will develop obstruction in the lower respiratory tract, which will cause increased work of breathing. That is nothing but your respiratory distress. So the patient will end up with using his or her accessory muscles. So typical increased work of breathing symptoms will start to show up, and like your nasal flaring in kids, subcostal retraction, intercostal muscle recessions, all of these things will indicate that the child is in respiratory distress, which is nothing but the increased work of breathing. And increased nasal, or rather mucus production, will cause again upper airway obstruction, and it'll because the nasal passages are smaller in the pediatric age group, which is why the obstruction will be more predominant, with even minimal amount of mucus secretions. And this will again add on to the airway resistance, hence increasing it. And like I said, all of this will ultimately cause respiratory distress, and particularly in the young infants who are majorly the nasal breathers. So in adults, at least, people can use their mouth for respiration, but in infants, they are predominantly, or rather infants are generally nasal breathers, and because of their small nasal passages and because of increased mucus production, that will lead on to increased airway resistance, will cause obstruction, and because of this, the patient will end up in respiratory distress, as depicted by your nasal flaring, subcostal, intercostal retractions, and all of it. Basically, child will end up with upper airway obstruction. And then when we talk about the virus per se, this respiratory syncytial virus, it's transmitted majorly by direct contact with contaminated secretions, which includes the large droplets into the mucosa of the eyes and the nose. So it's direct contact. That's how RSV spreads. And infected secretions, even if they fall on fomites meaning the non-living things around, like the towel, bottle, box, table, comb, clothes, all of these are fomites. So if these large droplets fall onto these fomites, they will remain contagious for several hours. So if the child happens to come in contact with these fomites, RSV gets transmitted, and the next thing you know is that the child ends up with bronchiolitis, which is why it's highly infectious. Viruses in general are very infectious, and uh, um, uh, uh, hand washing and contact precautions are of dire importance in this particular infection in order to limit the spread of the disease. Incubation periods, just like any other viruses, mostly it's within a week, child will end up with bronchiolitis if RSV has been transmitted into his body. Now, talking about the various respiratory rate, if it is the child is in infant age group, it will be about 30 to 60 breaths per minute. 1 to 2 years, it will be 24 to 40. 2 to 5 years, it's roughly between 20 to 30. 6 to 12 is 18 to 13, and more than 12 is 12 to 16. As we see, like from the younger age, as the child grows up, the respiratory rate keeps coming down. So if it crosses the upper limit, we can see that the child is tachypneic, which again is an indication that the child has respiratory distress. Now, when we talk about the risk factors of bronchiolitis, it is prematurity. That is, if the child is born within less than 37 weeks of gestational age, or if the child is less than 12 weeks of age, or if the child has any previous episodes of apnea, or with any underlying cardiopulmonary disease, immunodeficiency, chronic lung disease, all of these are the risk factors for bronchiolitis. And in these particular category of patients, that is preterm or younger kids, or with an underlying lung cardiopulmonary pathology, or if they're immunodeficient, or they are fighting a chronic long-term disease, in these particular group of people, if the child if they end up with bronchiolitis, then it can blow out of proportion, like it can become extremely severe too. Now, when you talk about the clinical features, it's quite simple because the child has ended up with the airway obstruction, increased airway resistance, and which ultimately causes increased work of breathing. Clinical features is nothing but be uh, like in terms of increased like respiratory distress. So the child can have tachypnea, wheezing, coughing, rhinorrhea, nasal flaring, use of accessory muscles, and obviously it's an infection, so fever may also occur. Now, these symptoms will generally last anywhere between 7 to 21 days, and they're often worst in the first week of their illnesses. So the peak symptoms will be somewhere towards the end of the first week, that is fourth or fifth day after the onset, and the child can become very irritable and sinus because of um, inadequate ventilation and poor feeding. There will be hyperinflation of the chest, and minimal crepitations can also be heard on auscultation. And apneic episodes may be brief and self-limited, or it can progress to more frequent and prolonged episodes, which signifies severity of the infection, and it can ultimately lead to hypoxia and the need for endotracheal intubation. So basically, due to inadequate oxygenation and ventilation, the child can end up in an intubated state. So moving on to the next part of the clinical features, we on chest examination we will find wheezing and crackles diffusely, because bronchioles will be affected and inflamed with edema and mucus production. So you will have, and because of the bronchospasm, increased airway resistance, there will be wheeze, and because of increased mucus production and also because of the edema in the bronchioles, crackles will also be heard, but it will be diffused throughout, including both the lung fields. And respiratory rate should be measured for about 1 full minute. And according to the respiratory rates that we discussed earlier, to that pediatric age group, we'll figure out whether the patient is tachypneic or not. and accessory muscle usage of intercostal muscles, or retractions, subcostal retractions, nasal flaring. All of these are the signs for respiratory distress. And respiratory distress worsens, meaning the bronchiolitis has increased in its severity. Risk of dehydration will also be there, because nasal passages will be blocked, so it will inhibit feeding, and it will also increase the work of breathing, and a high metabolic rate will also contribute to increased insensible losses. We assess overall, because a child will have decreased or rather poor feeding. We have an overall assessment of the child, wherein we assess for signs of dehydration. We look for any signs of respiratory distress, dehydration including the dry mucous membrane, tachycardia, lethargy, delayed CRT, inadequate urine output, sunken fontanelle. All these are the signs for dehydration. And if dehydration worsens, baby can end up in shock. So all of these have to be like taken into consideration. And shock features include prolonged, even more prolonged CRT. There'll be cold extremities, or change in the altered, or change in the sensorium. All of these will tell that the child has landed in shock. In that case, more aggressive therapy or treatment has to be taken, including endotracheal intubation if need be. Now, moving on to the diagnosis aspect, you should be strongly suspecting bronchiolitis in a patient who is less than 2 years, but majorly if it's an infant. And it's a clinical diagnosis. We look for wheeze and crackles and auscultations, respiratory distress signs, and the age group itself is a huge clue that the patient has bronchiolitis or not. And typical symptoms of respiratory or rather increased work of breathing, rhinorrhea, wheeze in a child of age group less than 2 years. Now, we also, while diagnosing this patient, because of increased airway resistance and obstruction, it is possible that the child can end up in hypoxia, and the most common cause for pediatric cardiac arrest is hypoxia. In fact, it is so common, or that the three major reasons for a pediatric cardiac arrest are all hypoxia. So that's how dangerous hypoxia is in pediatric age group, which is why we will obtain pulse oximeter at presentation to detect hypoxemia, and then on repeated assessment of the child, also we will keep in mind the saturation of the child along with the respiratory rate and work of breathing. Now, rapid viral antigen tests can be useful, but it is majorly a clinical diagnosis, and test results may be positive as long as the virus is being shed. Now, chest x-rays, even though on auscultation, wheeze and crackles, crepitations are heard, it is not really mandated to obtain a chest radiograph, but it can be considered when the illness is severe or associated hypoxia is seen, or if the course is not very typical. In these cases, chest radiograph can be asked for, although it's not really compulsory. Again, I stress on the fact that it is a clinical diagnosis. Now, if we do obtain, this is all that you will find on a chest x-ray. You don't find any consolidation patches or anything. It is majorly a hyperinflated chest x-ray because of air trapping, and increased bronchovascular markings can be seen because of inflammation. Otherwise, as such, chest radiograph might not show any features uh, that are like typical or specific for bronchiolitis. Now, moving on to the treatment, it is majorly the symptomatic management, and it involves frequent installation of saline into the nares, followed by suctioning. Basically, you're trying to clear the nasal air passages by regular suctioning, and installation of saline into the nares followed by suctioning, meaning you're giving a saline suction. That is because of increased mucus production. The secretions can be thick because it's mucus, so which is why you will give a saline suctioning. The idea is to clear the nasal passages, because nasal nares are like too small in pediatric age group, which is why any increase in mucus production will lead to profound upper airway obstruction, and that can lead to hypoxia and all the other adverse outcomes. So we will make sure that the child's airway is patent, and also that the child is not going into hypoxia, has adequate oxygenation and ventilation. Emergency medicine is all about ABC, airway, breathing, and circulation. So once we do this, the frequent suctioning, and make sure that the airway is patent, we tackle the next big problem, that is poor feeding. Now, the child might not be feeding well. In that case, we support for feeding. We support the child's feed by making it more frequent and smaller feeds. And in the use of pre-feed suctioning, basically you clear the nasal airway and then feed the child. That is the pre-feed suctioning. And caretakers should use frequent hand washing, that is in order to limit the chances of spread of infection. This is a flow chart, as we can see, and it involves or rather it is a flow chart to uh, treat bronchiolitis. When the child presents to the ED, you do the major assessment, like we take the history and physical examination. We rapidly assess the patient's overall airway and respiratory system. If the child is well, then we just do nasal suctioning as and when it is needed. We educate the caregiver on the steps to limit the spread of infection, like frequent hand washing and things like that. And we also tell them that if the child, we give them a list of red flag signs to watch out for, or how this illness can progress if it worsens. And we let them know that if any of these signs and symptoms are noted in a child, to bring the child to the ER as early as it's possible. And we arrange for an early follow-up with primary care physician, and then we discharge this patient home, keeping in mind that the child will be seen or followed up on an outpatient basis. Now, let's just say if at all our examination hints towards mild to moderate bronchiolitis, we go straight with nasal suctioning with normal saline, which is always going to be the mainstay treatment in order to clear the nasal passages. Then we check check the pulse oxy, or rather check the saturation via pulse oximetry in order to rule out hypoxia that can be more predominant. If a parameter that can go bad, if or rather worsen if the child is landing in severe bronchiolitis. And we assess the overall hydration status, wherein we look for child's signs and symptoms for dehydration, like mucous membranes, the sunken fontanelles, skin turgor, mental status, urine output. All of this has to be taken into consideration in order to figure out if the child is just dehydrated or has landed in shock. Then we keep assessing the child, and we observe the child for 2 to 4 hours, and we look how his feeding is. So, but if the following criteria is met, we straight away admit the child in pediatric unit. That is, if the child requires persistent oxygen, or if child has had episodes of apnea, or if child's feeding is so bad, or rather less than 50% of his normal feeding. In that cases, we admit the child for nutritional and fluid support, or if there is nobody back home to take care of the child. So in these cases, we straight away admit the child. But let's just say if our initial assessment of the respiratory system suggests severe or life-threatening apnea, then in that case, this candidate would be admitted in the ICU intensive care unit. And we go on with little aggressive management, wherein we go ahead with frequent nasal suctioning, and continuous pulse oximetry will be placed in order to rule out any hypoxemia. And then we try and maintain the saturation to be at least above 90%, and we assess the overall hydration status, rule out dehydration, shock, and we give supportive therapy to support his fluid and nutrition status. Then we also consider epinephrine nebulization, that is 0.1% solution and 0.5 ml and 3.5 ml normal saline every 1 to 2 hours. This is just to clear the airway and also to support his oxygenation ventilation status. And then we also consider dexamethasone as an anti-inflammatory agent combined with epinephrine. So if that actually epinephrine nebulization is not really a go-to treatment for bronchiolitis at once, we try with steroids. If steroids isn't working, then and if the patient is extremely sick and in a life-threatening state, that is when we consider nebulization of the epinephrine, basically the racemic mixture nebulizations. But otherwise, it is dexamethasone and can be combined with epinephrine. Like I mentioned, the child will be admitted in the ICU unit, and if despite all of these treatment of the child is not showing any signs of improvement, and then there is persistent hypoxia or increased work of breathing or altered mental status wherein we are looking at an impending respiratory failure or arrest, in that cases we'll also consider non-invasive ventilatory support or intubation as and when it is needed. But this option will always be should always be kept in mind. So this is the overall treatment. Depending upon the assessment, we'll divide the patient's condition to be absolutely okay, mild to moderate bronchiolitis, or if it is life-threatening apnea. So suctioning and steroids are in mainstay of treatment. If it is life-threatening, then perhaps nebulization of epinephrine will be tried. Moving on to the other part of the treatment, there are no benefits shown in hospitalization rates or the duration of hospitalization or improvement in the patient's overall condition, oxygen saturation, and all of it by using beta-2 agonists, that is your salbutamol, albuterol, and all. Basically, they have very limited or no proven benefit in improving the patient's overall conditions and hospitalization stay, which is why it should not be routinely given. And like I have already mentioned, the current guidelines advocate on steroid usage in combination with epinephrine. That is in order to curb the inflammation, which is the primary complaint or primary reason, the trigger for bronchiolitis clinical features. So we maintain an oxygen saturation of at least to more than 90%, and there is no much role of nebulized hypertonic saline usage, and non-invasive ventilation such as nasal CPAP, BiPAP can be utilized at an early stage if the child's work of breathing is too severe in order to prevent endotracheal intubation. But if that is indicated, if mechanical ventilation is indicated, we should be considering it. Now the last part would be disposition and follow-up. Majority of the cases of that present to the ED will not really have severe bronchiolitis, which is where they all can be discharged and treated on an OPD basis. But if, like I mentioned, the admission criteria is met and the child requests persistent oxygenation and there is nobody back home to take care of the child, in such cases we admit. But let's just say if the child is presented with apneic episodes, life-threatening conditions, signs and symptoms, red flag signs like altered mental status, or the child has landed himself in shock because of poor feeding, in such cases we admit the patient in ICU. But the major thing that we need to keep in mind is when we are discharging this patient from the ED, it is of dire importance that we educate the caregivers on the red flag signs so they seek help at the earliest if any of these signs and symptoms is seen in the child, like increased work of breathing, subcostal intercostal retractions, nasal flaring, or if the child is not feeding at all well, then immediate re-evaluation has to be done. And we demonstrate proper nasal suctioning techniques to the caregivers and counsel parents that the symptoms can, or rather may, persist to up to 3 weeks, and we avoid any unnecessary ED returns for persistent mild symptoms. But if there's red flag signs, we ask the patient to bring the child to the ER. We ask the parents to bring the child to the ER right away. So on this note, uh, we conclude bronchiolitis, and the last aspect would be the factors that can contribute, or rather risk factors that can hint towards moderate to severe bronchiolitis. Like, in what category of people will you strongly suspect uh, worsening? So in that cases, those category of people include premature babies, or if they're less than 1 month old, or if they have persistent tachypnea, increased work of breathing despite the oxygenation therapy that has been provided, or if the child is dehydrated, or if the oxygen requirement is less than 90% in room air. So when such category of people present at the ER admission, we can keep in mind worsening of the patient's condition. So we admit infants with witnessed episodes of apnea and those with risk factors for apnea, even if they appear well clinically. So that concludes bronchiolitis. Now moving on to our next topic, that would be croup. Now, croup is otherwise called as laryngotracheobronchitis, and it's the most common cause of stridor outside the neonatal period, and it commonly affects the age group of 6 months to 3 years, 3 years, with the peak incidence at second year of life. So, croup is synonymous to viral laryngotracheobronchitis, and it's since it's a viral infection again. It is predominantly seen during winter seasons, and the most common virus that is involved in causing croup is parainfluenza viruses, which is acquired through inhalation of the virus. And co-infection by more than one virus is also common. Bronchiolitis is RSV, and croup is parainfluenza viruses and rhinoviruses. Now, talking about the clinical features, the clinical course depends, that's highly variable, but symptoms are predominantly seen, or rather they will worsen in the night, and it will typically begin 1 to 3 days of nasal congestion, rhinorrhea, cough, and low-grade fever. So all these are the predominant symptoms that we will see. It is nothing, it's quite similar to having cold. The baby will present with nasal congestion, rhinorrhea, cough, and low-grade fever. And classical symptoms will include harsh barking cough. This is quite important because it is quite classical for croup. So harsh barking cough, hoarse voice, and stridor are the other classical presentation of croup. And severity depends upon how edematous or inflamed the airway is. So what we have learned from this slide is that the symptoms vary in their presentations. It will be worse at night, possibly because of cold temperature, and typically symptoms will be seen within 1 to 3 days, and it includes nasal congestion, running nose, cough, low-grade fever. Classically, when you think or when you see harsh barking cough, hoarse voice, and stridor, we think of croup. And severity is related to the amount of edema and inflammation of the airway. This is just like any other child which is presenting to the ER with the whole pat triangle. We assess for the respiratory aspect and look for features of any increased work of breathing, like tachypnea, any upper airway obstruction in the form of hoarseness of voice, stridor at rest, nasal flaring, subcostal intercostal retractions, lethargic or agitated child, and if there is any level of oxygen desaturation. So typical duration of symptoms will range from 3 to 7 days, and it is most severe on third and fourth day of illness. and then the child will gradually improve. Uh, just like bronchiolitis, croup is also a clinical diagnosis. They have very similar presentations. What sets croup apart from bronchiolitis is other classical symptoms that I just discussed about: harsh barking, cough, stridor, which is not seen in bronchiolitis. Bronchiolitis is more like wheeze and crackles. And laboratory investigations, viral tests, radiographs will only be needed if the child is extremely sick, has life-threatening features, or if the child is not responding to conventional therapy. Only in these cases do we order for these investigations. Otherwise, croup, just like bronchiolitis, is also a clinical diagnosis and also is caused by, it's also a viral infection and highly infectious also. If chest X-rays are ordered, they will provide physician an aid to monitor during the procedure, because agitation can worsen uh, uh, the patient's current airway obstruction. And there is one radiograph feature which is very classical of croup. I think majority of us must have heard of it. It's called as the steeple sign, wherein we see the subglottic narrowing. The X-ray which we will be discussing soon, we will see that the subglottic area will have a very sharp or narrowed region that is called as a steeple sign, meaning the church. It's also called as a church top sign. Uh, the subglottic area will be narrowed. It is quite classical for croup, but it is not routinely warranted to take a chest radiograph in a child wherein you're suspecting croup, because it's a clinical diagnosis. But steeple sign can also be present in normal children and also absent in 50% of the cases. So steeple sign is seen in croup, but it is not mandated that it should be seen in croup. Only croup, because normal children can also have subglottic narrowing, and steeple sign can be positive. Then using the Wesley severity score of croup, we classify the child to be mild, moderate, or rather moderate severe uh, categories, and depending on that our treatment varies. Now as we can see, this is the subglottic area and it has been narrowed, so this is steeple sign. It can also be absent in 50% of the patients presenting with croup. Now, this is the Wesley Severity Score, wherein we categorize the child as mild, moderate, severe, and impending respiratory arrest or failure. And to calculate the severity score, there are 5 parameters that we look into: level of consciousness, cyanosis, stridor, air entry, and retractions. So level of these are all scored from 0 to 5. And level of consciousness, if the child is normal, even if, and the child has like normal sleep, we give just 0 score. But if there is any alteration in the level of consciousness, then it's straight away 5. Altered mental status is a red flag sign, which is why if the child is presented to you lethargic or drowsy, or he's like super agitated, then or disoriented, confused child, it's straight away you give a score of 5. Then we look for cyanosis. If there is none, it is 0. And cyanosis again is an indirect factor for hypoxia. So if the child goes hypoxic with agitation, basically meaning that the child has increased work of breathing, and body is not able to keep up to the oxygen demand of the child with agitation, um, we give a score of 4. But if the child, even at rest itself, has cyanosis, which means to say that the child is hypoxic, which is why it is straight away we give a score of 5. And stridor, meaning that there is upper airway obstruction, subglottis narrowing is way too much, so none is 0. And if you hear stridor when the child is agitated, it is 1. But even if at rest you hear stridor, it is straight away 2. Now, air entry, it is 0, decreased will be 1, and if it's markedly decreased, it will be 2. And retractions, none, 0, mild give a score of 1, moderate 2, and severe 3. So this is how you're going to assess the severity of croup using the Wesley score. And depending upon which category the child falls under, management varies accordingly. So let's just say if the child is in the mild category, that is the score is 2 and less than 2, then we just treat the patient on an outpatient basis, and single dose of dexamethasone is what is prescribed to the child. And home treatment, meaning it will be a supportive treatment using antipyretics, that is if the child is running fever or if the child is not having enough feed, so fluids. This is how we're going to treat the child on an outpatient basis, and the child will just present with occasional barking cough, no stridor at rest, mild or minimal retractions. No retractions or minimal retractions. But if the child has scored 3 to 7 on the severity score, then we will regard this patient to fall under moderate category. In that case, the child will have frequent barking cough, stridor will be present at rest, mild to moderate retractions with very little distress or agitation. In that case, we'll give single dose of steroid, that is dexamethasone. We will try nebulized epinephrine, even though it's not really the first line management. And and hospitalization is not really required unless the child does not really have proper care at home. If the caregivers are not capable or competent enough to take care of the sick child, is when we admit. Otherwise, hospitalization as such isn't required for moderate category. Severe category includes those candidates who are, or those kids who have scored 8 to 11, and they will present with frequent barking cough. They will have stridor at rest and marked retractions and significant distress and agitations. So in this case, it is straight away the child is a candidate for admission, and we provide dexamethasone. Now, depending upon the severity, it can be even given IV dexamethasone. Then we repeat the dosages of Resimix epinephrine, and admission will be required. And if it is improved after steroid and nebulized epinephrine, then we will de-escalate the child's treatment. But if the child has scored 12 or more on this severity score, then it means to say that the child is so sick that there is an impending respiratory failure. So this is a life-threatening croup. This will require an ICU admission, and the child will present with altered status, mental status, that is depressed level of consciousness, stridor at rest, severe retractions, poor air entry, and cyanosis will be seen in these kids, and they will require IV dexamethasone along with repeated dosages of nebulized epinephrine. And if the child worsens further and has not really responded to our initial management, then this patient becomes a candidate for intubation. Treatment involves, we don't really agitate the child too much because there is already subglottic narrowing. So agitated child can produce trivoter and further upper airway obstruction, which is why we place children in a position of comfort, most commonly in the lap of their mother or just the caregiver, and where the child is more familiar and more comfortable with the person. We make the child to sit in a comfortable position, and then we do our overall respiratory assessment, wherein we observe the child to have any respiratory distress, any increased work of breathing, any stridor, how's the air entry, oxygenation. All of these will be assessed, but we will not disturb the child, because agitation and crying, like I mentioned, it will again increase the oxygenation demand, and it will further cause airway obstruction, and it will worsen the child's condition. So the multiple trials have been conducted in the past, and humidified air or cool mist is not really shown or proven to improve the child's condition. Now the current guidelines states corticosteroids and racemic epinephrine, nebulized epinephrine for all. Now, when we go in detail about the individual drugs, that is when we talk about epinephrine, mild croup will not require epinephrine, but those with moderate or severe croup who will require nebulized epinephrine, we'll observe them in the ED for about 3 hours before we discharge this patient. And if the patient worsens in this 3-hour period, we will straight away admit and we will increase the frequency of nebulizations. Epinephrine is known to decrease airway edema because of their vasoconstrictive effects on alpha receptors, which is why it's also used in bronchiolitis to reduce the airway edema. Now, effects will be seen within 10 minutes, and the effect will also last for more than 1 hour. But if the child has persistent symptoms or if the child is higher on the scale of severity, then repeated doses of nebulized epinephrine can be tried. Then use of epinephrine decreases the number of children with croup requiring intubation, ICU admission, and admission to the hospital itself in general. So talking about the corticosteroids, all patients with croup, whether mild, moderate, or severe, will benefit from oral steroids, which is why oral dexamethasone is given in mild to moderate croup. And if the child is in severe state, then IV dexamethasone is what is tried. So it reduces the severity and duration of symptoms because it curbs the inflammation that has led to airway edema and obstruction. So a single dose of 0.6 milligram per kg per oral is what is recommended, but doses as low as 0.15 milligram per kg can also be tried. And onset is considered to be 4 to 6 hours. Steroids generally take a good time, a good while before their effects kick in. So it is 4 to 6 hours after oral administration. Uh, the onset of action this is stated, and effects can be seen within 1 hour of oral administration. Helios and all the other things that has been tried, but all the other things have been tried, but they've not proven to be or show any major benefits. Like Helios, which is nothing but 70% helium and 30% oxygen. Theoretically, it is known to treat severe refractory croup, but there are no much studies or trials that have been performed in the past that backs this statement. Then there's no definitive advantage, and like I mentioned, beta agonists are not recommended for the treatment of croup, nor is it recommended for the treatment of bronchiolitis. And now summing up our group under this heading of group pharmacotherapy, dexamethasone is given for all mild, moderate, severe croup. Budesonide is another nebulized steroids which can be given if patient has vomiting and paroral is not something that the child is tolerating or cooperating with, and nebulized epinephrine, but this is only used if the child is in moderate to severe croup. Otherwise, as such, for mild croup, epinephrine nebulization is not really required. And then there is something called as a racemic epinephrine, that is you given the dosage of 0.05 ml per kg per dose, and this is again, like I stated, will be used in the moderate to severe croup, and dosages can be repeated as and when it is required. Now moving on to the last entity, it is disposition and follow-up. Most children, just like bronchiolitis, can be safely discharged to home, and those who have received nebulized epinephrine has to be observed in the ER for about 3 hours and looked or rather reassessed for their overall status, including the respiratory assessment. And children with persistent strident, even at rest, tachypneic, those having retractions or hypoxic will all require hospitalizations, along with on and off or rather repeated doses of nebulized epinephrine. And intubation is reserved for those cases which are either too severe or they are life-threatening. In that cases, and they're not responding, or medical failure, medical management failure, in those cases, we'll go ahead with definitive airway secure placement, and intubation is when intubation is necessary. But if it is necessary, we use endotracheal tubes that are smaller than recommended for patient age in order to avoid any trauma to the inflamed mucosa. And this would be the criteria for discharge. That is, we have observed the child for about 3 hours post nebulization of epinephrine, and the child seems absolutely well and is able to eat well, feed well, and caretaker are in a position or are competent enough in order to identify the red flag signs and report to the ER immediately. In that cases, also you can discharge the child, and also if they can arrange for an early follow-up and can reach out to the hospitals uh, when need be at the earliest. In those cases, we will discharge most cases of croup unless and until child is having severe or life-threatening. Even moderate croup can also be discharged, provided this criteria is met. So this concludes croup. So moving on to our last topic, that is pediatric asthma. So asthma is a chronic disease which is characterized by episodic and reversible airflow obstruction due to bronchial smooth muscle hyperreactivity and inflammation. So the bronchial smooth muscles will get hyperactive, or rather they will get inflamed and hyperactive or reactive, and it will cause airflow obstruction. But the thing is, this airflow obstruction is reversible and it's episodic, and this defines asthma, and it is responsive. One of the most important thing and also a good thing about asthma is that it is extremely responsive to dilator bronchodilators and corticosteroid treatment, which is why more than 95% of the children aged less than 2 to 18 years present to ED with asthma exacerbations like wheeze, shortness of breath, cough, disease, dyspnea, all of this secondary to airway obstruction because of bronchial muscle, smooth muscle inflammation will get better if they are right away treated with bronchodilators and corticosteroids. Milder cases will only present with wheeze or just little breathing difficulty, but severe exacerbations, in severe exacerbations, child can land up with dyspnea at rest, inability to speak, marked increase in work of breathing, and associated peak expiratory flow will be less than 40% of the predicted value. So asthma patients who present to the ER can vary anywhere between mild cases to severe exacerbations, but either way, whichever end of the spectrum they fall in, they are responsive to bronchodilators and steroids. And it's a reversible thing, asthma exacerbations. Now talking about the pathophysiology of asthma, it involves inflammation of the bronchial smooth muscles, bronchospasms because of hyperreactivity and contractions of the bronchial smooth muscles, and also that can cause airway obstruction. Now, all the exacerbation signs and symptoms revolve around these three causes or these three reasons, triggers. Either the bronchial smooth muscle is inflamed, or the child has bronchospasm, or has landed himself with airway obstruction. Now, all of this will cause, now when we individually talk about these things, inflammation as such, these people are very prone to any kind of allergies and infections. So any of these can trigger an inflammatory cascade, and the child can end up with um, uh, increased airway, or rather increased airway resistance. So bronchospasm will decrease airflow, and triggers include infection, irritants, or allergens. And allergens that precipitate bronchospasm will be a result of IgE-dependent release of histamine, leukotrienes, and other mediators from the mast cells. Now, when you talk about the inflammation, it will be airway mucosal inflammation causes airway mucosal edema, which will cause airway obstruction, and that will cause mucus hypersecretions, formation of mucus plugs, and structural airway changes. So that is how the inflammatory factor cascade, once set off, will cause edema, obstruction, hypersecretion of the mucus, causing formation of mucus plugs, and ultimately leading to structural airway changes, causing increased airway resistance, leading to increased work of breathing. Now, there is another term called as airway remodeling. Now, airway remodeling means hyperplasia and hypertrophy of airway smooth muscles, subepithelial fibrosis, and thickening of the subbasement membrane, which can eventually progress, leading to loss of lung function. So the bronchial smooth muscles, when they are repeatedly exposed to all the triggers, the irritants, then in that cases, the bronchial smooth muscles will undergo hypertrophy and hyperplasia, which is called as airway remodeling. Now, moving on to the clinical features and assessment, a thorough detailed history has to be obtained in order to determine the progression of the illness, the trigger that has set off an exacerbation, and the ability for ongoing care at home and for disposition planning. For all these things, a thorough detailed history is going to help us in the management. Now, we identify the possible triggers, whether it's a viral illness, LRTI, which has caused an exacerbation of bronchial asthma, or if the patient has been exposed to allergens or like pollen grains or any irritants, or if the patient has ended up with any non-IgE mediated allergic response. So in all of these cases, bronchial asthma can exacerbate. Then we ask about any previous hospital admissions, any previous attacks of bronchial asthma, or any prior ICU admissions, whether or not patient was put on any invasive, non-invasive airway support. All of this history will help us assess how severe the asthma currently is and what should be expected in the prognosis of this patient. Will this patient go bad, or will he have a quite uneventful course of illness? All of this, it will provide a hint. And we assess the airway and breathing immediately, and we keep assessing, the patient in order to see how well the patient has responded to our management, or if any alteration has to be done, or if the patient is prognosing poorly, and any need for invasive, non-invasive mode of ventilation is required. All of this will have an idea only if we assess and reassess the patient frequently. And respiratory rate, air entry, will give an insight on how adequate the gas exchange or ventilation is in this and that particular child. So when you talk about the assessment, we determine the oxygen saturation at present in order to rule out any hypoxia. Plus, we continuously monitor the oxygen oxygenation status of the patient, and identify early if the patient is going severely ill, or if the child is ending in or landing up in hypoxia, which is why oxygen saturation at presentation and serially is important. And we provide supplemental oxygen if the saturation drops to less than 92%, and we try and maintain it above 95-96%, because very high saturation of oxygen will decrease the minute ventilation. Minute ventilation is nothing but the product of respiratory rate and tidal volume, and it will result in elevation of the ETCO2, basically meaning that there will be PCO2 retention. Now, if oxygen saturation remains less than 92% even after initial treatment, we will consider that the asthma is going severe, or it's worsening, and it is leading up to either pneumothorax or pneumonia, and will require more aggressive management. Now, we consider ETCO2 monitoring in all patients who have landed in severe or life-threatening asthma, in order to see if the child is worsening even further, or if there's any requirement for ventilation, either non-invasive or invasive ventilation, depending upon how the child has worsened. And PaO2 should be lower than normal in children because increase in oxygen saturation, like I mentioned earlier, will cause decrease in minute ventilation, meaning that the child can end up with PCO2 retention. Now, accessory muscle will reflect the work of breathing, and it will also reflect on whether or not, accessory muscle, it also reflects the work of breathing, which is necessary in order to overcome the auto-PEEP and airway resistance. Meaning, because of increased bronchospasm, increased airway resistance occurs, and because of this there will be air trapping. Air trapping will cause hyperinflation of alveoli, and that itself will cause auto-PEEP. Auto-PEEP meaning positive end expiratory pressure. So that is required, it's the minimum pressure that is required in order to prevent collapse of the alveoli. Now, because of hyperinflation of these airways, of the alveoli, there will be auto-PEEP generated, and if increased auto-PEEP is there, then it will again cause increased work of breathing. It will again increase the airway resistance, and it will worsen the patient's respiratory distress. And accessory muscle requirement progresses in a caudal to cephalad direction. So basically, subcostal intercostal muscles will occur, and then it will move to the progress to the cephalad direction. As in, first your subcostal intercostal muscles will be affected, then eventually there will be nasal flaring, usage of neck muscles, sternocleidomastoid muscles will be seen. So the respiratory distress progresses, or the accessory muscle usage progresses from the caudal to cephalad direction. And wheezing is pathognomic of asthma, as there will be bronchospasm, which will cause airway obstruction. And it will be more during expiration rather than during inspiration. And wheezing is actually a good sign, because if the wheezing decreases, and then the child will end up with silent chest. So one might hear wheezing, one might hear that there is absolutely no breath sounds, like there's no wheeze in a child. So you might get confused thinking it's just mild asthma, because wheeze is not that profound. Now the thing is, you should, in that cases, you should take into consideration patient's other clinical features. And if other clinical features are pointing towards severe or life-threatening asthma, like altered mental status or something on those lines, then silent chest has to be considered. So in that cases, once we start nebulizations and steroids in those patients, then and if the patient is improving, then in that cases, the silent chest will eventually progress or rather will get better, and you will start hearing profound wheezing upon auscultation. So it's actually a good sign. So once you hear a silent chest and then you hear wheeze, then it actually means that the child is progressing good. So silent chest is not a good feature. It is in fact a feature of severe or life-threatening asthma, and there can be a lot of confusion that can arise when we're clinically assessing the patients, which is why an overall assessment of the patient's respiratory status has to be taken into consideration. Because in such patients, the ones with quiet chest or silent chest, the airway is severely compromised and will require more aggressive management, including ventilation, like mechanical ventilation. Now then, there is something called as the Pediatric Respiratory Assessment Measure, that is PRAM, wherein we take into consideration another like 5 parameters, which hinge towards respiratory distress, suprasternal retractions, scalene muscle contraction, air entry, wheeze, how's the oxygenation status of a child, and room air. Now, depending on that, it is scored as 0, 1, 2, 3, with the maximum score being 12. So 0 to 3 is mild asthma, 4 to 7 is moderate asthma, and 8 to 12 denotes severe asthma. So PRAM scoring is important, as it can give a hint to whether or not, or will give a hint on treatment plan and our disposition plan. Now, diagnosis is essentially revolves around asking three major questions for the child with signs and symptoms that suggests asthma exacerbation. One, is there a past history of child having asthma? Or is it the first time the child has landed up with something which is raising suspicion for a bronchial asthma? Because if the child is already an established case of bronchial asthma, then this is nothing but just, then you can, like quickly come to conclusion that the child could perhaps have had another episode or exacerbation of bronchial asthma. And then the second question that you'll be asking is, how bad is it? How bad is the airway exacerbation? How severe is it? And then third one would be, what is the possible triggers? Is it an allergen? Is it an LRTI infection? Is it any allergens? Yeah, infections, allergens, all of these things have to be like uh, 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 taken into consideration, because if at all it is because of any infection and the child has ended up with pneumonia, LRTI, in that cases we'll have to treat the trigger, like we have to treat the infection and also simultaneously give or manage the exacerbation. Then then it will reduce the hospital stay and duration. Chest X-ray is, again, like I mentioned, not routinely advised in pediatric asthma cases, but this would be the indications for chest radiography in acute asthma. One, if fever is not explained by apparent viral illness, or if there's a chest pain, cardiovascular instability, or if there's absent breath sounds, and that is only to rule out pneumothorax, because asthma is notorious in causing pneumothorax. Not very common, but it can present. The susceptibility is more, or if they respond poorly to treatment, we'll have to think of any foreign body aspirations, or if there's any congestive heart failure possibilities. All of this has to be considered, or if there's any life-threatening exacerbation, and we need to consider any alternate diagnosis to check for any underlying chronic lung disease. In all of these cases, chest radiograph is warranted. Otherwise, on a routine basis, chest X-ray as such has very little role to play in bronchial asthma diagnosis. This is a picture of chest X-ray of bronchial asthma. As we can see, it's just hyperinflated lungs with increased bronchovascular markings. Now, if there was a pneumothorax underlying, then we could have seen a collapsed part of the lung border, and absent uh, 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 bronchovascular markings. But as such, this patient doesn't seem to have any pneumothorax. It's just hyperinflated lungs with increased bronchovascular markings. Now, this is the treatment aspect. I'm not sure how clear this slide is, but depending upon our PRAM score, that is 0 to 3 being mild, 4 to 7 is moderate PRAM score, and 8 to 12 is severe, and then there is impending respiratory failure. So depending upon these scores, there is, if at all it is mild, then we keep assessing the patient every hourly. If it is 4 to 7 moderate, then we assess the patient every half an hourly, and if it is severe, we assess the patient every 15 minutes. So the treatment aspect remains the same. It is usage of beta 2 agonists like albuterol, salbutamol, short-acting beta 2 agonists, as they will provide instant relief, and they're also asthma patients are very responsive to that therapy along with steroids. And we have frequent monitoring of the vital signs also. So peak expiratory flow can also be taken into consideration in order to classify this patient upon the severity. Like in cases if it's a mild asthma, then peak expiratory flow rate will be more than 70%. If it is moderate, then it will be 50 to 70%, and if it is severe, then it will be less than 50%. So this is the PRAM scoring, and depending upon this, you will have treatment plan. And if the patient worsens even more or has landed up with altered mental status and PCO2 retention, severe hypoxia, in that case, or not responding to our initial medical management, those patients will end up with impending respiratory failure, and those patients have to be monitored continuously because they can develop or they can land up in cardiac arrest anytime. So in that case, systemic corticosteroids should be used as soon as possible along with beta-2 agonists, and supportive management and securing the airway becomes utmost priority. Now moving on to the treatment aspects, you have a short-acting beta-2 agonist, that is the bronchodilators. We add an anticholinergic nebulization like the ipratropium bromide if asthma has become moderate to severe or life-threatening exacerbation. So we give nebulizations of both salbutamol and ipratropium bromide. Then there is systemic steroids. That's for all patients with moderate or worse exacerbations. Oxygen has to be maintained above 95. Saturation has to be maintained above 95%. So if it falls less than 92%, we supplement the patient with oxygen. Magnesium sulfate is to relieve bronchospasm, and nebulized magnesium sulfate is not recommended. It is only intravenous magnesium sulfate which is recommended commonly, and then there is inhaled corticosteroids, but it has like no acute ED management role because they take a long while for the action to kick in. Now these would be the dosages for medications of asthma exacerbations: salbutamol, ipratropium bromide, and then systemic steroids includes prednisolone, methylprednisolone, and dexamethasone. Other medications that can be used in order to relieve bronchospasm would be magnesium sulfate. Now let's just say if the patient has landed himself in severe or life-threatening asthma and we are planning on intubating this patient, near fatal asthma. In that cases, then the induction agent of choice for intubation will be ketamine. Why ketamine? Because it has an added effect of bronchodilation. So that will be given in the dosages of 1 to 2 milligram per kg per dose. Magnesium sulfate dosage is 25 to 75 milligram per kg per dose. Salbutamol, depending upon the child's age, the dosages vary, but it is generally 2 to 4 puffs. So this is the dosages of asthma exacerbation drugs that are used. So treatment of near fatal asthma, when clinical signs progress and the patient has ended up with worsening hypoxemia, increased respiratory distress with respiratory muscle fatigue, child is not able to talk well, or altered sensorium, all of this hint towards near fatal asthma. In this case, the initial management involves in securing the airway. So early intubation or early usage of non-invasive non-invasive airway support like CPAP, BiPAP has to be considered. BiPAP is the preferred mode of non-invasive airway support in a patient, and early usage of BiPAP prevents intubation. So it will deliver different pressures during inspiration and expiration in order to decrease the work of breathing. It will keep the airways open and it will improve in the gas exchange. It will also have some amount of bronchodilating effect too, which is why BiPAP is the preferred non-invasive modality for airway support, and early securing of airway is the key. And when we are planning on intubating the patient of asthma, our preferred drug of induction or the preferred agent for induction is ketamine. We use a well-fitting face mask and close attention to the patient. Comfort is essential because if the patient is agitated and not cooperative to the BiPAP, or if there is no well-fitted face mask and there is air leak in all of that cases, then it will lead to failure of non-invasive mode of airway support, and the child can end up in intubation. So most patients will tolerate BiPAP, but sedation is frequently required if they are not very cooperative with low doses of benzodiazepines, generally 0.05 to zero 0.1 milligram per kg of midazolam, or ketamine can also be given as a sedative agent just to calm the patient down as an anxiolytic. Now, talking about endotracheal intubation and assisted ventilation, the key pulmonary mechanics of the disease process is one, hyperinflation. Second is generation of autopeep, like we discussed earlier, and markedly prolonged expiratory time that results in the failure of airway to empty, which causes air trapping and increased airway resistance, which will again increase the patient's work of breathing. So once the endotracheal tube is in place, appropriate tidal volume and sufficiently low respiratory rate has to be considered. One, because prolonged uh, uh, respiratory rate, basic low respiratory rate, prolonged respiration causes enough time for the airways to empty. So expiratory emptying will occur and it will avoid hyperinflation and generation of autopeep. So the ventilator mode is set in such a way that the respiratory rate is low and tidal volumes are low and long expiratory duration is set along with high flow rates. When we talk about the drugs for rapid sequence intubation, ketamine is given in the dosages of 1 to 2 milligram per kg. Rocuronium can also be used as a paralytic agent, that is 1.9 to 1 milligram per kg, and then other drugs like vecuronium can also be used. But as an anxiolytic, fentanyl or midazolam are the preferred agents. But in children, fentanyl is not really a go-to drug. When you talk about the ventilator, controlled hypercapnic hyperventilation is a recommended ventilator strategy. That is controlled hypercapnic hyperventilation. So that, which is why we'll have like low respiratory rates and we prevent PCO2 washout as such. And the aim is to minimize the hyperinflation and airway pressure while we provide adequate oxygenation to the child, and it will also help in airway or expiratory emptying and prevents hyperinflation, prevents autopeep, and prevents increased airway resistance, which leads to increased work of breathing. So all of this can be tackled provided we have long expiratory time, low tidal volumes, and low respiratory rate with high flow rates. And the child has to be cooperative and comfortable, which is very important as it will avoid ventilatory, or rather if the child is a non-invasive mode of airway support like BiPAP, then it will prevent breath stacking. And if the child has been provided with adequate sedation, it will avoid ventilated dysynchrony. So these would be this is just to give an idea of the initial ventilator settings that we aim for if we were to intubate a child with pediatric asthma. And the mode would generally be a PCV mode or a synchronized intermittent mandatory ventilation, that is SIMV mode or PCV mode, and pressure regulatory volume control, yeah, mode. And then the tidal volume will be aimed to achieve at 6 to 10 ml per kg of respiratory rate 8 to 15 cycles per minute, inspiratory time of roughly about 0.5 to 1, and expiratory time, as we can see, it is prolonged. So the highlight here is prolonged expiratory time, low respiratory rate, and low tidal volume, like 6 to 10 ml per kg is what we will aim for. Now, talking about the disposition and follow-up, most patients should be observed for at least 1 hour after the most recent bronchodilator dosage. And then we look, or rather frequently assess the patient's overall prognosis. If the child is deteriorating, it is straight away criteria for admission. But if the child is doing quite well for himself, then in that cases, we can safely discharge the patient after adequately educating the caretakers. And a PRAM score of 8 or higher at 3 hours after ED presentation will predict the need for admission, which is why frequent assessment of the child with bronchial asthma is essential. And those patients who are to be discharged or treated on an outpatient follow-up uh, um, outpatient basis, then in those cases we let the caregivers and the child, we educate the child to avoid any possible identifiable triggers like pollen allergies and any irritants that has been identified in the past, which can trigger an exacerbation. And we also prescribe the child with an inhaled short-acting beta-2 agonist. An age-appropriate valve holding chamber must be prescribed with meter-dosed inhalers, and proper instructions for the technique to use the inhalers should not just be taught but also should be reviewed at after every ED presentations. You should review on the technique that the child is using in order to use the metered dose inhaler. And patients treated with systemic corticosteroids should be prescribed a 5-day oral course. So these would be the instructions that need to be followed when we are discharging a patient with pediatric asthma. So this concludes pediatric asthma. Thank you.